Once again, my name is Terri Skirven, and I am from Philadelphia, Pennsylvania. I'm Director of Therapy at the Philadelphia Hand Center, and I will discuss now therapy for patients with Dupuytren's contractures. I think it's safe to say that hand therapy following surgery for Dupuytren's contracture is accepted practice, notwithstanding the fact that formal study and literature support is lacking. On the other hand, preoperative therapy has been studied, particularly splinting, and while not widely used, the reports of pre-op splinting showed some beneficial effects, and I think it's interesting to look back and see if we can learn anything from these prior studies. So Messina and Messina back in the early 90s looked at this device. They called it the TEC, or the Continuous Elongation Treatment Device, which was surgically implanted, and found that there was some opportunity to straighten out these Dupuytren's contractures. Other studies were also reported, and these were all devices that were surgically implanted. The Pipster, the one at the top, was felt to be lower profile than the one that the Messina's introduced, and perhaps more accepted by patients. More recently, Roz Evans is looking at the serial casting technique again for preoperative contractures with Paul Dell, and all of these investigators report that when followed by surgery, the surgery seems to be more simplified, there are fewer complications, shorter rehabilitation time, and the patients have improved PIP extension. They also, some of the reports were that there was an avoidance of necrosis of skin and need for skin grafting, an avoidance of the loss of vascularity, and in some cases the need for finger amputation was avoided. However, the studies did show that the contracture would recur once the device was removed. I do think it's interesting to look at the Messina study, because when they first started to use this device, they used it without the intention of post-removal surgery. And so they did report that they had 15 patients that used this, and it was on for 2 weeks duration. 2 millimeters a day of elongation was applied through the device. And then once it was removed, there were 20 hand therapy sessions and ultrasound used, as well as a night extension splint. And they reported at about a 3-month follow-up that 6 patients actually had no reoccurrence of the contracture, and 9 patients had reoccurrence, but to a lesser extent. And all of the patients in this initial sample determined or decided not to have fasciectomy. And so I think it's interesting to look at that there is some potential perhaps with preoperative or non-operative splinting. At any rate, I think a single pre-surgery visit by the hand therapist with patients who are going to undergo surgery is helpful, although it's not always possible and not always covered by insurance. But to establish a baseline assessment and then to talk to the patient about the postoperative management. Many patients, we've heard this already, will say, if I had known what was involved, I may not have elected to have the procedure. Well, I think the therapist can help the patient understand that there will be some restrictions temporarily in their use of their hand with work or leisure or other activities, and it will help them to plan for those limitations and problem solve so that they're not taken by surprise and they have less anxiety. Postoperatively, the focus initially and most importantly is to maintain the contracture correction that was obtained at surgery, and this is by and large through splinting. And then on the flip side, to restore finger flexion, which oftentimes is limited because of the volar scar and some difficulty that the patient has with flexing against the sutures and with swelling and things like that. So, and particularly with the more extensive procedures and multiple digits and sites that are involved, the patient may succumb to significant stiffness and limitation in motion. So what is the evidence or what has been documented about postoperative splinting? Well, we're lucky to have 2 investigators here that will speak after me, Dr. Meinl and Debbie Larson, who will speak about splinting following contracture release and the studies that they've done. Dr. Gelberman and colleagues back in 1992 reported an interesting study where they looked at the use of dynamic splinting continuously for 4 weeks postoperatively. excuse me, and performed range of motion exercises out of the splint, but then applied the splint once the exercises were done. This was day and night for 4 weeks. Then after that time, at 4 weeks, they used a static night splint, and then the dynamic splint was continued during the day continuously, and the exercises were continued. And then at 8 to 12 weeks, the dynamic splint use was reduced to intervals of time during the day, sort of a weaning process, and the night splint continued for up to about 6 months or so. And they found that the patients that were compliant with this regimen, which you can imagine is pretty rigorous with a dynamic splint continuously for that period of time, they had 59% improvement in the patient's PIP extension at 2 years. The non-compliant patients, 25% improvement. And so their conclusion was that this was a helpful and useful way to maintain the surgically corrected PIP extension. More recently, Roz Evans is looking at the effects of mechanical stress on results after fasciectomy and has introduced the no-tension approach to postoperative splinting and management following Dupuytren surgery. She advocates a dorsal block splint. The MCP joints are flexed at about 45 degrees. The PIP and DIP joints are allowed to be gently extended within the splint. It's applied 24 hours postoperatively. And her hypothesis is that by not subjecting the healing tissue to tension and stress, postoperative flare incidence may be reduced. There's a reduced incidence of scar problems, hypertrophy of scar, and tenderness. The time in therapy may be reduced and outcomes improved. And she has extensively looked at the literature to supply a rationale, but basically the mechanical stress on digital vessels and nerves may contribute to local hypoxia and inflammation, and tissue anoxia may contribute to an adverse cellular response, and that hypertrophic scar can form in response to tension. And so basically what she does is the dorsal block splint with gentle exercises within the limits of the splint. The patient is limited in terms of performing full extension by virtue of the dorsal block splint. And then she does some basic wound care and edema control. Within the splint, this is a little splint that I've made, that it's a hand-based dorsal splint. The MPs are flexed, the PIPs are gently extended, and the patient can just undo the straps and perform gentle range of motion within the splint as well as blocked extension. They're allowed to achieve fairly maximal PIP extension because of the fact that the MP is blocked, putting slack on the volar tissues, and it allows them to achieve that. And because it's applied early, postoperatively, the straps can be used by the patient to gradually coax the finger and the PIP joint into greater extension against the limit of the splint. The patient is cautioned with these not to extremely stretch their finger or abruptly do it, but to allow it to gradually extend in those days following its initial application. And after 3 weeks, then the patient is allowed to come out to full neutral extension or composite extension of the digits. And so the splint is actually changed to become a volar splint with a finger supported in neutral extension. The risk can be included if there's evidence of or a history of carpal tunnel syndrome. And then during the day, if necessary, finger-based PIP extension splints can be applied for intervals of time to, again, maintain the PIP extension. Occasionally, patients will tend to lose extension once the splint is weaned from continuous use during the day, particularly because their hand is in a relaxed position, they're starting to use their hand, so there's much more of a stress or emphasis in flexion with function, and so it's important to keep an eye on that and to supply whatever sort of measure, whether it's these little splints or other types of things, to have the patient maintain their extension. So Roz looked at her results, and basically what she did was she looked at retrospectively a series of patients that was treated with a more traditional approach of initial maximum extension, and then she did a prospective study after she came up with this technique looking at patients that were treated with the no-tension approach. And comparing the two, she found that there was improved motion with those patients that had the no-tension approach, decreased flare rate, decreased scar rate, shorter, fewer therapy visits were needed, and all in all, it was less expensive. Now, I think it's interesting to look back at some of the other modalities or motion modalities that have been used. Dr. Sampson and colleagues back in the early 90s looked at continuous passive motion. and it was applied within 3 days post-op, used for about 8 or 10 hours a day for 4 weeks. This was combined with a standard protocol of night extension splinting for 6 months and home exercises and scar management. And basically their results was that there was really no clinical benefit with the use of the CPM compared to a standard approach without CPM. We at in Philadelphia had the opportunity to look at a series of postoperative patients with CPM, including following Dupuytren surgery, and our observations was that the CPM was well tolerated, that swelling and wound healing was not adversely affected, and we used this with open palm technique patients and others. It seemed to facilitate the recovery of motion, particularly with multiple digits involved in the open palm procedure at an earlier point in time than with just standard techniques. And the observation that I had was that precise fitting of the CPM unit was critical. The therapist, not the sales vendor, would need to be involved in fitting it to make sure that there was a precise fit. And then it was also important to emphasize to the patient that the machine wasn't going to do all the work. We don't use that because you can get good results with standard approaches, and the CPM requires a lot of finagling to get it to fit, and insurance coverage is kind of spotty, and patients end up getting very overwhelmed. But I think it's an interesting modality that might be useful in some situations. Other aspects of the postoperative management are wound management early on to prevent infection and to take care of the wound, debriding dead tissue, and applying appropriate dressings. And therapeutic exercise, depending upon what the patient's clinical evaluation shows, where their limitations are, we're focusing on a variety of exercises, joint isolation exercises, tendon gliding, etc. I think that I agree with and certainly have noticed the difficulty with preoperative severe PIP flexion contractures with a boutonniere type appearance. And so what's important for these is to emphasize PIP extension actively, because they may, out of surgery, have full passive extension, but they have a lag because of the attenuation and weakening of that central slip. And so the therapist needs to emphasize PIP extension as well as DIP flexion with the PIP straight to stretch the oblique retinacular ligament and to stretch the lateral bands. And Dr. Smith just presented his work looking at the attenuation issue, and I think that this makes a lot of sense. This is the little gutter splint that could be used for the continuous period of time for 3 weeks, and this is the Capener splint. And for those that are not familiar, a Capener is simply a spring-loaded splint that assists extension but allows flexion. And the nice thing about that with a situation where you have an extensor attenuation is that it assists the extensor tendon but allows flexion, so you're sort of balancing out the power in favor of the extensor. Other exercises, intrinsic stretching and blocking splints, are used to focus the force of the patient's flexor tendons at the IP joints. And then this is important to remember, no pain, no gain has no place in a hand therapy and in a postoperative situation. Over-aggressive exercises, I think, can incite an exaggerated and prolonged inflammatory response. And patients, family members, and others need to be reminded that, because they are likely to want to overdo, and this can really backfire. The exercise frequency it's daily. The patient needs to understand that just coming into therapy is not enough. They need to do home exercises, and it's modified according to the patient's response and the presence of edema or other types of problems, and so the therapist is really evaluating at every session to modify the exercise protocol as well as the splints. Physical agents such as heat and cold, ultrasound, and electrical stimulation are all used in supervised therapy for various reasons to optimize the patient's exercise program. For problem patients, iontophoresis with dexamethasone has been used for burning pain or painful scars, and the other aspects for swelling are compression gloves, Coban, and galvanic stim for edema. And this just shows some of the types of techniques and things that are used for edema. Isotoner gloves, compression gloves, digi-sleeves, and those types of things are very helpful in controlling the postoperative swelling. Scar management is also an issue, and these scars sometimes can be quite raised and irregular and tender, and so you can use various techniques. Roz recommends micropore paper tape along an incision to prevent wound tension, and it's found that this has minimized scar widening and hypertrophy. Massage is important, and pressure. Silicone gel sheets and putty elastomer pressure application are used for these scars. I've been working long enough before these became popular, and I was always amazed at how patients following Dupuytren surgery, within 2 months or so, these scars would be smooth and just regular looking, as opposed to what they look like the first few weeks post-operatively. So while we use these, I think that sometimes patients do okay without them. By 4 to 6 weeks, the patient is weaning from the splint during the day, but they do continue the night splint for 6 months to maintain the surgically corrected extension, kind of like someone wears braces on their teeth, is how I explain it to our patients. And the other modalities are continued, and light strengthening has started to be incorporated, with caution that the patient should not do over-repetitious gripping like some people tend to do with putty or a ball or hand grips, because this can actually precipitate carpal tunnel syndrome and triggering in the presence of some of the residual postoperative swelling. Occasionally, patients have some persistent problems with extension or with flexion, and so various types of dynamic or static progressive splints or straps can be used to try and encourage maximum range of motion in flexion or extension. And Roz, this is Roz's splint with the serial casting to finally correct a PIP contracture, and also to include a traction on the DIP joint to stretch the oblique retinacular ligament and the lateral bands to achieve greater DIP flexion. And finally, the patient needs some counseling in terms of return to functional activities. It's surprising how many patients will say, "You mean I can't go back to golf tomorrow after 2 days after surgery?" And so they need to understand that their hand is healing, and they need to be cautious with activities, and they need some counseling as to how they're going to manage some things with regard to work, self-care, and other activities. Thank you. Okay, and moving right along.